The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and good morning to those of us that are still on the West Coast. Welcome to the first webinar in our Nutrition Division webinar series. My name is Bernard Hernandez, and I am Chief Information Officer here at DM&A. Thank you so much for taking the time out of your busy schedule to join us today. We know your time is busy and valuable, so we appreciate you being here. Just a few housekeeping logistics before we begin. During the webinar, the phones and your computers will be on mute, and you will be in listen-only mode throughout the duration of the webinar. There will be a question and answer session at the end of the presentation. In order to ask a question, please type it in using the questions box in your GoToWebinar control panel. Please take a second to locate that on the control panel, probably on the right-hand side of your computer, unless you move that. You can type a question anytime during the webinar, and we will answer as many as we can during the Q&A period. Those that we don't get to, we will reply via email after the webinar. Also take a second to look for the polls tab on your control panel. Michelle will be asking a couple of polling questions, and you can put your responses there in the polling tab. And also take a look at the handout tab. There we have a link to the download of the webinar PDF. So if you want to print that out and write out your notes and stuff, you can download that and print that out while Michelle is doing the presentation. It is my distinct pleasure to introduce our speaker today and my good friend, Michelle Mathura. Michelle joined the DM&A team in 2010 as a success coach. As director, she leads the nutrition division team in providing education, coaching, and support to hospitals all over the country. She provides our clients with the right tools to improve the overall nutrition care process, documentation, reimbursement, and patient care. Michelle holds a bachelor's degree in food, nutrition, and dietetics with a minor in chemistry from North Dakota State University. She is a registered dietitian and a certified diabetes educator, but most importantly, she is wife to Randall and a mother to their almost one-year-old daughter, Lillian, whose birthday is coming up in just a couple of weeks. So without further ado, please welcome Michelle Mathura. Take it away, Michelle.
Thank you, Bernard, and thank you all for joining us this afternoon. I'm really excited to be with you today to talk about a subject that I'm very passionate about and that my colleagues are, and I know many of you are, because you're taking time out of your busy day to take a little break and learn a little bit more about malnutrition and caring for your patients with malnutrition. We decided to discuss this topic because of its timeliness. The Academy of Nutrition and Dietetics has been working hard advocating for malnutrition to be part of the quality reporting with CMS. And in April, it was the 24th, I believe, it came out with the CMS reporting for proposed reporting measures that malnutrition is proposed and could be our fiscal year 2018, one of the quality measures. Now, I hope many of you got the email from the Academy prompting you to go and submit feedback to support this measure. I know we did, and I had to remind myself a few times to do it. You know, we get busy in our day, but I believe I clicked on the link the other day, and it is closed. I'm pretty sure. If not, somebody knows it's open. You can put that in the little message board. But I know they were looking for some feedback, because our goal is to be able to take care of patients and identify them with malnutrition. So to have that as part of a quality measure in our hospitals would be phenomenal. So we're just as excited as you all are, and we're excited and thankful for the work the Academy of Nutrition and Dietetics did. So I'm going to go over just a brief history about malnutrition and some updated statistics that we found. The global prevalence of malnutrition, 25 to 50% of our patients are admitted every year with some type of malnutrition. And when we're talking about that, we're thinking of protein calorie related malnutrition. So think about the patients that you see. Do you think this is a high number, or is this kind of where you're thinking when you're assessing patients that, yeah, 25 to 50% of my patients I'm seeing on a daily basis have some degree of malnutrition? Estimated worldwide, 20 million children under the age of 5 have some type of, are severely undernourished. And undernourished and malnutrition are a similar definition. So undernutrition or undernourished malnutrition in developed countries generally occurs with acute and chronic illness. Now we do see this when we assess in the hospitals and coach dietitians and physicians on identifying malnutrition, both in the adult and pediatric population. And it's amazing how many opportunities we have as dietitians to improve our screening and our assessment skills to really identify the proper diagnosis of malnutrition. And we see it frequently in the United States, mostly, of course, in our hospitalized acute and chronically ill patients and children with special needs. So we can all agree, and the consensus is that malnutrition is a worldwide problem. We think of undernourished and malnutrition. I might think of undernourished as the person who maybe has a higher BMI. They're still malnourished because they're not getting the right nutrients in, but they might have excess amount of non-nutrition calories, but not just the right amounts of proteins and different types of micronutrients and macronutrients. And so malnutrition can occur at any age in your life, at any weight, but we know that they lead to poor health-related outcomes and also can have a longer length of stay, and they're frequently readmitted. But the work that you do as dietitians, screening, assessing, and providing patient care and the nutrition intervention make a huge difference. And so my guess is, and we'll find out in our polling questions, that most of you have some kind of initiative going on. It's been a little over 7 years in the making, since, or actually should be about 6 years, when the Academy of Nutrition and Dietetics in Aspen released the malnutrition characteristics for diagnosing malnutrition that came out in 2011. So hopefully everybody's using those, have them, working on using them, so that we have a best practice tool. We also find that the diagnosis of malnutrition is going to be a little bit, or quite a bit different, I should say, than the coded diagnosis of malnutrition. So we see a big gap in what is medically diagnosed from the physician standpoint. So the physician, the dietitian, they write diagnoses. The dietitian writes the nutrition diagnosis, the physician writes the medical diagnosis. That percentage is at 25 to 50% that we saw earlier. But the coded diagnosis, in a report from the Agency for Healthcare Research and Quality in 2013, so that was 4.5% of all inpatient stays. So what was actually getting coded was a lot less than what we're actually seeing diagnosed. And our experience with our customers that we train and coach on caring for malnutrition in our malnutrition education and training program, we see about 5.6% coded malnutrition of all inpatient stays, and that's just the last 6 months of our customers in 2016. Now, that being said, we can talk a little bit more about the coding piece of it. That's not part of the quality measures that you'll see, though. They found that that's not something that is going to impact patient care, the coded piece of it. It does, though, however, impact the financial health of the hospital, because it impacts what we're seeing from the severity of illness. So what type of patients are you seeing at your hospital, and how do you compare it to the hospital down the street? You really want to be able to speak to that. So even though the coding piece of the whole process of malnutrition in a hospital isn't part of the quality measures, we still want to show the importance of that. Okay, so malnutrition in the hospital, we typically see about 10 to 15% of the time the patients that are diagnosed with malnutrition have some degree of malnutrition, whether it's moderate or severe protein calorie malnutrition. About 10 to 15% of them, that's their only comorbidity. So what does that mean? That means that we hope that with the work that we're doing, and we see that we do see that diagnosis, and then we work with coding and documentation to get that coded as well, because that's very important. If it's their only comorbidity, it impacts, again, the number of days they have in the hospital that are covered by insurance, and it impacts the insurance taking care of that patient from a financial standpoint, so that we, the hospital, can provide services. The diagnosis of malnutrition, as you may see in your hospital, and we see quite often, continues to vary among healthcare providers. And so it's our job, I feel, partnering with CDI and coding to get the best practice tools out there so that we can educate physicians and also get our CDI and coding teams on the same page. We don't want to be querying for albumin. So I share all of this as a background, because when I talk about where are we with malnutrition, prior to this CMS announcement. So there has been a lot of work that I know by a lot of people, and the Academy and Aspen have done a lot of work, and we have done a lot of work coaching and educating people on site, in the trenches, we may say, on the floors working with patients. And it's just awesome to see all the heart that goes into this and the caring that comes from our profession. So malnutrition in the hospital, we know, leads to increased complications, poor and decreased wound healing, like I said, increased length of stay and risk for readmission. So if this isn't something you're tracking, these are good things to look at as well. So I want to know, after I did that little brief overview for you all, I'm going to hit our first polling question here. And the poll's in progress. So this is what I need you to answer. Number one, click 1 if you are currently using the Academy and ASPENS characteristics for malnutrition for assessing and diagnosing, but you're not tracking any data related to it. So that would be number 1. Click on that if that's you. Number 2 is you're currently using the Academy and ASPENS characteristics for assessing and diagnosing malnutrition, and you're tracking some type of data related to malnutrition. Number 3, you may have began using the malnutrition characteristics, but you're not fully using them. So you may be using, like, the intake and the weight loss, but you haven't been trained on the physical assessment piece, or you're not comfortable with it, so you're not fully using the characteristics, and you're not tracking data. That would be you, number 3. So why don't you guys take a minute and let me know where you are with this. We'll take just a few more seconds. I think I almost have everybody answering. Okay, so Bernard, I do have a question. If I hit close, I still see my answers, correct?
Correct.
Okay, thanks. Okay, I'm going to go ahead and close that. So we have 29% of the people are using the characteristics, which is awesome, but they're not tracking data. So this today, you think about some data you'd want to track. 47%, the highest amount, you're using the characteristics and you're tracking data related to malnutrition. Wonderful. That's where you want to be eventually, because if you can't show it in black and white, it's hard to say you're doing it, right? So we want to have some data related to what we're doing from a quality perspective, from a severity of illness perspective. We want to be able to show what we're seeing with the work we're doing with malnutrition. And about 24% of the group that we have on our call today started using the characteristics, but they're not tracking data and they're not fully using the characteristics. So this is a great opportunity for you as well to just learn a little bit more, get empowered, and learn some resources. So thank you. Okay, so let's talk about these future considerations for inpatient quality reporting that CMS has proposed for fiscal year 2018. Now remember, when we say fiscal year 2018, that means October 1st, 2017 is actually the federal fiscal year. So this is why we did this webinar first in our series, because our fiscal year will be coming up soon. And I feel like I'm in an awesome position because I'm just a sharer of good news. So today I'm sharing some good news with you that we're hopefully these proposed measures will go through. So electronic clinical quality measures, ECQM, for malnutrition. So what is a clinical quality measure? It's a measure that helps track, or a clinical quality measure is a measure that helps look at the quality of care that your hospital is providing. There are many measures that CMS shows available, but in fiscal year 2018, they want you to report on 6 of the 15 for hospitals choosing to participate in them. So they help measure and track the quality of healthcare provided by eligible professionals, hospitals or critical access hospitals. And it's a voluntary program, but the benefit of it is that you'll be able to get some good feedback, look at where you can grow as a hospital and do better, but also there's incentives from Medicare as well that the hospital can gain. So these measures use data associated with the provider's ability to deliver higher quality of care and long-term goals. And you'll see my link at the bottom there if you want to read more about it. This came directly from that website, the CMS.gov Regulations and Guidance website. And the CMS.gov, I'm sure you've been on it for other things. It's got a lot of great tools on there. So the CQMs measure health outcomes, clinical processes, patient safety, efficient use of healthcare resources. And I think about that, like efficient use of healthcare resources. That's huge. Care coordination. Are you guys involved in care coordination? A little bit maybe? Are you working with case management? We think about that with our malnourished patients. Are we helping coordinate care upon outpatient discharge? That's important. We take a good care of our patients in the hospital, but we also are sending them home, and they came in malnourished more often than not. So how are we helping with our care coordination upon discharge? Patient engagement, population and public health, and adherence to clinical guidelines. The adherence to clinical guidelines, we think again, now what clinical guideline have you chosen? It looks like many of you have chosen the clinical characteristics for the Academy and Aspen malnutrition characteristics, which are the ones we definitely would want to use. So the people that are participating in these CMS electronic health record incentive programs, they can be any eligible provider, hospital, CAH, inpatient psych facilities, or any Medicare providers that are in acute care, patient prospective systems that are, except for cancer hospitals, long-term care, inpatient psychiatric facilities. And more often than not, you know, I can't imagine a hospital not wanting to participate if they accept Medicare. So again, it's hospitals' participation, but they do get incentive programs when they properly record and share their data. So here are the future considerations that CMS has proposed related to malnutrition. The first is the completion of all malnutrition screening within 24 hours of admission. So think about how you are screening your patient. Have you taken the opportunity to look at your current screening tools? And I'm guessing this 47% that's been using the characteristics and tracking data that you have done that. If you haven't, I encourage all of you to look at your screening. You want to use a validated screening tool to identify those patients with malnutrition. You want to make sure that your tool is, if it's an electronic tool, which I'm sure 90% or more of it is, that electronic tool, once you have a positive screen, that it speaks to the dietitian. So it sends out a request for a consult or for an assessment on that patient. So we want to make sure that, you know, the electronic health record is working for us. And we want to review and update our current screening to make sure that we're not seeing patients we don't necessarily need to see in the hospital. We want to look and say and be able to answer the question, when I walk in this room and I'm looking at this patient, is there a nutrition risk? And so a validated tool, like the MST tool by Marie Ferguson, the malnutrition screening tool, is a validated tool for malnutrition. So keep that in mind. That would be one of the quality measures CMS has proposed and looked at for future consideration. The second one is the completion of a nutrition assessment for patients identified as at risk for malnutrition within 24 hours of a malnutrition screen. So now some of you might be using low, moderate, high risk tools. And on your high risk, policy and procedure, or standard high risk policy and procedure, you might have like within 24 hours or 48 hours. So this says that we want to complete that nutrition assessment for our patients that are identified at risk for malnutrition, so got a positive screen. We want to provide a nutrition assessment within 24 hours of the screen. So it would be cool if your electronic health record could remind you. You know, you can also write it down and, you know, pay attention to the time. This might add a little bit of extra focus and work for those hospitals that don't have dietitians on the weekend, but I say bring it on, because think about nurses and PTs and OTs, maybe not PTs and OTs as much, but nursing and physicians, you know, other clinicians, pharmacists, they're on around the clock. And you might think, oh, is this going to, you know, cause more work on our part? Well, it probably could cause a little bit more, but we could also look at, you know, we work with hospitals on figuring out, okay, staffing and productivity and, you know, where we can help them be more efficient. And so we want to assess whether these patients age 65 or older, and that's really what they're looking at, is 65 years or older. But my thought is, and my recommendation, why not everybody? You know, why would we just, I mean, Medicare, of course, is 65 and older, and they're focusing on that. But even if you had a 30-year-old, why would you wait more than 24 hours to see them? Because malnutrition is serious. We're looking at a serious comorbidity. And if you think about your average length of stay, which I encourage all of you to know what your average length of stay is at your hospital, it will help you. You don't want to wait, you know, like a few days, because how is that nutrition intervention going to be effective? Are you going to be able to see that patient? Because when we're doing a nutrition assessment, this would be a fun one just to get people's, you know, voice, your feedback, but we have you muted, so we can't do that, and that's okay. But for a nutrition assessment, that requires an in-person looking at the patient in the room, discussion. It's not from your computer. That's not a nutrition assessment. You can't do a full nutrition assessment from a computer. You know this if you're doing hands-on physical assessments. And what we teach, practice, and preach is anybody requiring a nutrition assessment requires a physical assessment as well, a nutrition-focused physical assessment. So if that's an area of opportunity, you think, oh man, we really could grow in that, but how do we have the time to do that? Contact us, we'll help you out. We really, when you are fully capable and you're trained to your best effort in the hospital with your patients, you get that training, you get that confidence. It only takes a minute or so on average to, provide that assessment. And that's half of the guidelines that we're looking at, those characteristics. So it's something that we definitely want to see all dietitians doing and learning in school as well. But we know that there's still a lag there, but there's a lot of good work being done on that. So I spend a lot of time on this nutrition assessment piece because that's where we're going to get all our information. And we can't do a full-on assessment and get the most valuable information if we're not seeing the patient. And I know some of you might be thinking, well, why wouldn't you want to see the patient? But there are still hospitals out there that are just, they're maybe, are short on dietitians, or they've had a lot of outs, or they just think, hey, this is the way we've always done it. We see some, but we see some from the computer. But really, we need to see everybody in person when we're doing a nutrition assessment. That is best practice. Think about if you were in the hospital, would you want the physician to just, view you from the computer or the dietitian? Not. We wouldn't want to see that. For our family members, we wouldn't want somebody assessing them from a computer. We'd want them in person. So I'm empowering you to think about that. And if your hospital chooses, if this goes through and your hospital chooses malnutrition as a quality measure as one of the 6 they need to report on, and I think you can report on more than that, but that's something to consider. And even if it doesn't go through, this is still what we should be doing. And I would encourage you just to see all patients, because that's important, and just caring for the patient and really getting our intervention started and to be able to be utilized in the hospital. Like we did say that malnutrition, patients with malnutrition who are diagnosed do have a typical longer length of stay. But we do see sometimes that they'll go home sooner because of various reasons, but then we typically see those ones come back into the hospital when we run our data. All right, so since I've talked about the nutrition-focused physical assessment, I want you to think about the second one here. Now, Bernard, I didn't share the results from the number 1, so my number 2 I don't think popped up. So should I hit share and the number 2 will pop up?
If you click the down arrow, you can select the second question.
Okay, it's not, oh, there it is. I'm sorry. Okay, thanks. See, I'm learning, guys. So we're going to launch this one. Okay, thank you, Bernard. So this is you yourself, dietitian, answering. I provide a nutrition-focused physical assessment on all patients that require a nutrition assessment. Would you say that's 100% of the time? A. B, 75% of the time. C, 50% of the time. D, less than 25% of the time. Or E, you do not provide a nutrition-focused physical assessment to your patients at this time. And it could be that you're just, learning and training, and you haven't started it yet, or you're looking for somebody to help you learn. And that's okay. Any answer is fine. I'd like to know from this group where we're at with that. So we're going to give you a few minutes to answer. We'd love to get 100% feedback here. We have many people on the call today, which is just wonderful. Give you just a few more seconds. Numbers are still coming in. Still coming in. I'm going to give this enough time so that we can really get some good feedback. And think about it too, if you're not providing the nutrition-focused physical assessment, or if you are, wherever you are at, if you have interns, wouldn't you want them to learn that? So that's something, like, think about when you're advocating for this, if it's something that you've been kind of getting shut down about at your hospital. Maybe they think it's not valuable, or you haven't been able to speak to it and get approval yet for training. You can speak to it in terms of best practice, patient care, how it impacts malnutrition, then also how it impacts those you're educating in the internship. Okay, I'm going to go ahead and close, and then I'm going to share the results this time. So we see that 21% of the time, 100% of you are doing it, every patient. And you can see the rest of the results, I believe, as well. 25% of the time, 75% of you, excellent. 15% of the time, about half the time, 50% of you about half the time, and then 20% either don't do it at all, and then the other 20%, less than 25% of the time. So we definitely have some work to do in terms of getting to that 100%. That's the gold standard. That's best practice nutrition assessment patient care. And if whatever your challenge is there, excuse me, feel free to reach out and we can try to help you overcome that and give you some guidance. That is something that we do provide as DM&A on-site training for the physical assessment, and we have for the last 5+ years. So that's something that you really want to get some good training and be able to do it, and because then you'll be fully using the guidelines for diagnosing malnutrition. And you want to do that because as one of my colleagues and dietitians said, and I hope maybe she's on today, but remember it was a year after we were working together, and she had been a dietitian for 15 years, and she's the lead dietitian, and she said, Michelle, I just think about all those patients that I didn't check under the covers, I didn't physically assess, and all those patients that I missed out on their nutrition risk, malnutrition, just because we just weren't doing it. So there's always time to improve and move forward. So thank you for your feedback. Okay, moving along. The third quality measure is nutrition care plan for patients identified as malnourished after a completed nutrition assessment. So we're doing this, right? If we're identifying a patient with malnutrition, we did their assessment, then we provide the best nutrition care plan for that patient. And so that's something that we want to think about from an inpatient setting, but we also want to think about it from an outpatient, or not outpatient, but a post-discharge, which could include like an outpatient referral. So when you think about it from an inpatient setting, are there thoughts that you have right now or things that you've been working on? I want you to think about this a little bit that you've improved on. Are we working with the patient, for in a room service setting, educating them, helping them with choices? Are we using that tool? Are we following up on supplement usage? Like, is that a good supplement for the patient? Is it left in the room? Are we utilizing our hosts and hostesses in a room service setting or a diet clerk or diet tech to be able to help kind of follow up as well? Are we talking with the patient about their plan for home? Are we talking with case management and social work about the plan for home? Because what I find over the years of working with hospitals and patients and even thinking about from a personal standpoint, my dad had severe protein calorie malnutrition right before he died, probably for about, I would say, 3 months. And it was very difficult to be a dietitian in this world of malnutrition and, just bring out every single trick that I could find, anything, any recommendation. And it actually took other dietitians, and of course, you never listen to your family. He listened a little bit, but to be able to, identify different things like Meals on Wheels or, just and to have the family member accept. And so you have a huge role in that because the patient will hear from you, the clinician, the non-family member, and take your advice. So thinking about home, these patients are coming in malnourished most often. Some become malnourished in the hospital. But when they come in malnourished, they're going to go home probably to maybe they go to skilled nursing or have home health come in or maybe just back to their same environment. And so we really have to think about, when we're writing our PES statements, what is the why? Like, why is this going on? Why are they, with moderate protein calorie malnutrition, why are they not eating? Not just because of a poor appetite, but what's causing that poor appetite? Think about your intervention for home and for the inpatient setting. Is that one that you want to send home? Because if they're home by themselves, what's going to work best for them? Can they get around their house? Are they depressed? do we need to talk to family about eating together and the value of that and the importance of that? A lot of people before they pass away do have some degree of malnutrition. It's not, when we look at our data, it's usually not like the admitting diagnosis. It's usually like a second or third diagnosis, but they're coming in because of dehydration or falls or COPD, CHF related admissions, but it's usually not like the reason that they're there is because of malnutrition, but it's something related to that was caused by it. And so, you know, it's interesting thinking about my dad. The one thing I learned, and this was years ago, was that all his medications were making his mouth dry. And that's something that I don't find a lot of dietitians ask about, but now I coach all of them too, is how about dry mouth? And that's what was a lot of the reason it was causing him not to be able to want to eat, because of that dry mouth. And so there's all kinds of interventions we can do for that. So like, it's just important to think about the whole nutrition care plan, and then we want to make sure that care plan is on the discharge summary and the discharge instructions, because we want to get it to the patient, and if that's something that you're not able to get to them, but that packet of paper to get to them is important with all their other appointments, maybe an outpatient appointment as well. So that's going to be a quality, hopefully, I act like it already got approved, but hopefully that will be a quality measure as part of the quality measures that we're looking at as the whole of malnutrition. We want to make sure that this nutrition care plan for patients is written down. It's the best that we can provide. And I know we all want to do the best. And sometimes it takes us a step back to think about, okay, this is what we've been doing, this is what our team's been doing, but how could we make it even better? How could we even bring it up a notch? And then the last, but not least, is looking at the documentation of malnutrition. Now, in the beginning, we talked about the difference between documenting and diagnosing malnutrition, or no, sorry, diagnosing and coding malnutrition. Malnutrition diagnosis is a medical diagnosis, and then dietitians do a nutrition diagnosis. So a physician, a provider, an MP can do, or a PA, so providers and physicians can do a medical diagnosis of malnutrition. The dietitians do a nutrition diagnosis in the United States. In Australia, dietitians can do medical diagnoses, but not in the United States. So we provide a nutrition diagnosis. And those of you who were saying, yes, we do 100% malnutrition characteristics and we're collecting data, you probably have some sort of setup where your nutrition diagnosis goes to the physician somehow so that they can see it, they're alerted. And so everybody should be looking at some type of communication. There are so many different things you can do in the electronic health record, you know, and then also communicating during rounds, during interdisciplinary rounds, patient care meetings, just seeing the patient or the physician on the floor to speak to that, but also from an electronic standpoint. Or if you're still in the paper world, some hospitals are a form that you could provide, because we want to make sure that the appropriate documentation of a malnutrition diagnosis is in here. So this is like what all of these measures we've been talking about for years. So it's really awesome to see that this could be a CMS quality initiative, which is, I'm just very excited about. So once we have the diagnosis in the chart, we want to have it in the progress note, and I'm speaking to medical diagnosis, but also in the discharge summary. Confirm with your coding department, confirm with CDI that this is what we want. That's the best places for the medical diagnosis if you have a coder who's going to code it. That's where they would want to see it, not just, you know, showing up in the discharge summary. It has to be during the patient's stay and not just in the dietitian notes. The physician needs to speak to it. So that's cool. We want to see that in there, and we'd love to see it coded higher than, you know, that 5.6%, 7% on average. It's like 5 to 7% of the time. But what I find is that, or we find in our team, you know, some coding teams stop when they get so many MCCs, which are major comorbidities or comorbidities, so diagnoses that CMS accepts as a comorbidity, so complication, and they only do so many. But then we see some teams that are coders, and they'll just, you know, code as many as they possibly can. And it really, I think, in our experience, we find it depends on the staffing. it depends on, kind of their quality initiative program in their department and what they have time for. But we always encourage, that malnutrition diagnosis, if it's able to be coded, to get coded, even if it's not the only comorbidity, because it still reflects what's going on with that patient, which is the severity of illness with the patient. You can have more than one code. And the risk of mortality, so there are risk of mortality scores related to that. And these are hospital, I call it the financial health of the hospital, but looking at, that, and this is not where, CMS is probably going with the coding piece, because again, it doesn't impact the patient care. And if you read the report, when it came out for the electronic clinical quality measures, it speaks to why they didn't add the coding piece. But to have the appropriate diagnosis from a patient team aspect to take care of the patient, so everybody knows what's going on with that patient. Malnutrition is rampant and it's in our hospitals, so we want to make sure that we're speaking to the same thing. We don't want the dietitian to be saying severe protein calorie malnutrition and the physician to be saying, oh, it's just mild. They don't know the severity of it. So that's where the dietitian and physician would need to communicate. And I'll tell you one tip that that we use in our team quite often is dietitians will say, but how do I talk to the physician? What if they didn't write malnutrition, or they wrote like overall good general health and I found malnutrition? Like, how would I speak to that? And we say, just going to the physician and saying, I see that you've identified mild malnutrition, or you didn't identify malnutrition. I did a complete assessment using these guidelines, and this is what I've identified. Did you see similar things, or is there anything that I didn't see that you caught, that you saw? I want to make sure that we're on the same page. It shouldn't be a scary conversation. I know some physicians are tougher than others, but what we find overall is that physicians look to us as the nutrition experts, and they're like, yeah, just, you're doing a great job. You're the expert. Show me what you do. Tell me what to do. Majority of the time, that's what they're wanting. They want our expertise because we are the experts. And so getting your diagnosis in there, the appropriate one. So that means if we go back, we have to do an appropriate screening and assessment to find them, and then to take the time to do a nutrition care plan. And then when you have that, you can share that with the physician and then find your medical diagnosis. Okay, so those are the 4 measures that have been proposed. And I'm going to share with you some tools too from the Academy on that and how you can track them. But I'm just going to share with you a little bit about what we do from the Nutrition Division standpoint. And then we're going to have a little bit of time here talking about or answering some of your questions. So if you haven't, put any in, start thinking about them and start adding them in there. So for the last 7 years, we've provided education and training to over 40 hospitals, including 6 health systems in the United States. So many, dozens of dietitians, hundreds of dietitians that we provided on-site nutrition-focused physical assessment to. And it's been awesome to see the aha moment and to realize that when working with dietitians, after a patient or 2, you guys are set. You're good to go in the competence piece of it, most of you. And then, we run into patients that might be a little more challenging, so we keep working together. But we typically will spend about 3 days on site. Excuse me, those allergies. If it's just physical assessment training, we spend about 3 to 4 days on site working with dietitians on that. And that's important. You can watch webinars, you can go to trainings at conferences, but to work with your own patients is where we see the best come out of that, because then you can be trainers to new dietitians and interns as well, and really build your skill into competencies. Malnutrition education and training, caring for malnutrition in your hospital should be a dietitian-led program. So wherever you are, you're probably working tight with CDI and coding, which you should be, absolutely, but you're the drivers. You are holding the torch, you're leading the path, and you're the advocates for this program, for this focus, for these patients. And I just encourage you to utilize the tools you have. I think probably many of us haven't even really looked at the measures other than today. That's why you're here today, which is great. But I encourage you to go to the CMS website too. And I can actually we'll maybe send out the PDF from CMS with our surveys too, so that you have that easy tool. But you can find it on the Academy website as well. Education, training, and coaching we provide wherever you are in your program process. In the beginning, when we started doing this, it was like full-out blown program because it was just the beginning. But now we're finding, like many of you, you're doing you're using the characteristics. You have done some data. Maybe you haven't done any data focused related to malnutrition. Maybe you still need to provide education to physicians or get on the same page as CDI, or even looking at like, how can I improve my program? What else can I do? Because we've been doing this for a few years, or where are some of the challenges lying? So we help people wherever they're at in education, training, and coaching as experts in this field. We have dietitians all over the United States that provide on-site training and off-site support as well. So if it's an interest to you, please contact us. We'll have information at the end of the session about that as well. Like I said, we can help you wherever you're at, and we'd be happy to do so. The value and the purpose of a program. So you might not call yours a program, but maybe you do. But it provides training and tools to effectively implement the evidence-based guidelines. And so that's what we provide to coach and train, not manage, but to empower you. And it really elevates our role, doesn't it, as dietitians in the healthcare setting, to be able to speak to like a value and purpose in the clinical setting. So we've seen that over the last 7 years, with dietitians and the focus and all the resources that we have between DM&A and the Academy and Aspen and the malnutrition.org, the Alliance, a lot of great tools. And so it shows that we're breaking down those silos and we're collaborating with CDI coding physicians, food service, admin, IS, like all of our departments, working together for the patient. And it shows, again, our value to the healthcare organization. And if you think about it, if we look at the value of us, are you getting asked like to show productivity reports? Are you getting asked like, well, do we really need this many dietitians? That kind of thing. You need to be able to speak to that, and that's something that we can help with as well, because we typically see that we're either good on staffing or we're needing a little bit more help. Not within our teams per se, but when questions that come to us, or people that just want us to do kind of an overview of where they're at to provide support of their team structure. When you're able to demonstrate positive patient outcomes with caring for malnutrition, it's going to be nice if this goes through with CMS and the quality reporting, because you'll have an awesome tool to use, but in addition to the tools that you're already using. And when you think about data, we really want to think about not just reimbursement-related data, which is very important, of course, because it shows reimbursement to our hospital that's legitimate, that impacts with the diagnosis of malnutrition. But also like looking at average length of stays, who's coming back in, and auditing these charts, and are there ways that we can improve as a healthcare team? Patient satisfaction, financial outcomes, from the severity of illness and risk of mortality scores. And these might be new words to you, but when you put that nutrition diagnosis down for malnutrition and the physician agrees to it and also puts down a medical diagnosis and it gets coded, that's all positive to the hospital. It helps keep the doors open. It helps keep the patients taken care of. We need to support the team and the patients accurately diagnosed, instead of just saying malnutrition and it's still albumin related. We don't want to see that, because we know albumin is not a criteria to diagnose malnutrition, but we still see physicians doing that. So just as a side note, when you're educating physicians, it's not really a one-time deal, and many of you probably have realized that. It's like continuously going back and, hitting the new physicians, the residents, the locums, the traveling physicians, but to be able to continuously, provide education. They've got a lot coming at them, and that's why they look to you, the expert. It's a challenge for a dietitian to really up our game, improve our skills, and to do the best that we can to get some job satisfaction. Think about what is the value? How do you enjoy being a dietitian? What is it that you love most about the work you do? I see a lot of dietitians that, this really just kind of gives them a new fire, because they're able to provide even more than we did before. And so I'm excited for all of you. So identifying and caring for malnutrition, again, dietitian-led initiative, improves patient care and outcomes, helps prevent readmissions and admissions, improves our inaccurate documentation, which again, all of this is related to these electronic quality measures. So a lot of you could already be doing this. Some of you will need to, start working on it if, your hospital chooses to pick this as one of their reporting measures, which I really hope that all of you do for the patient care piece. There are a lot on the CMS website and a lot that your quality team is probably looking at. But if you're going to look at the incentive program and look at, well, what measures will we report on, and it could be, if this passes, that we'll be able to really up our game, because if we're providing a nutrition screen, then wouldn't you want to provide the best practice? If you're providing the characteristics or the nutrition assessment, we would want to use the best practice tool. Because if we're not using the best stuff, then why report on it? Like, it's not going to tell us what we need, and it's not taking care of our patient in the best way. So here are some links. I'm not sure if you're going to be able to link to them from a PDF, but you can copy and paste that the Academy has. I love the press release. You probably have already seen it, but read it. It's really good, from our Academy president. And then they have links to tools, basically, from the eatrightpro.org website that you can track these quality measures. Amazing tool. So click on those. And then there's also a malnutrition quality improvement initiative. They're working in collaboration with the Academy and Abbott, and this is where these actual quality measures kind of started, and CMS adopted and looked at them. So that's really interesting to look at and to read about. And I love it, defeat malnutrition. That's what we want to see. We're identifying it in the hospital, but part of our program is once we identify it and got the hospital program going, then let's get outside into our clinics. Let's start finding it before we end up in the hospital and take care of those patients too. I hope you can hear my passion, and I know you're passionate about this this subject. It's very important and near and dear to my heart, as well as our whole entire team. And we're just here for you to support you. And I'm going to click it over to questions that you have. So let's look and see what kind of questions are coming through. So if you haven't, take a minute and look here.
Thank you so much, Michelle. Yeah, definitely we can hear the passion in your voice, and we know that this is something that's very important for all of us in our everyday jobs, and ultimately to improve patient care. So yes, folks, at this time, if you haven't done so already, please type your question into the question box in the control panel, and we'll get to as many as we can, and those that we don't, we'll compile the answers to that and share that with the entire group or individually, depending on the question. So yeah, Michelle, do we have any questions from the audience?
Yeah, we have a few really good ones. I mean, a lot of great ones. And like I said, like Bernard said, we probably won't get to all of them, but we'll get to as many as we can. So I like this one here. How to best utilize the DTR, the dietetic, or the diet tech in the malnutrition diagnosis process, especially if assessments are only to be done by the RD. What I've seen work really well in hospitals is the screening process. To do some additional screening. And the MST is one of the malnutrition screening tools. That's a validated tool. And if you go on the evidence analysis library, you'll find other validated tools. But the MST is what's current or popular in use. That can be done by a nursing, of course, but it also could be done by a diet tech. And if you have a diet tech that can, screen your patients, even at that length of stay screening, typically we see 7 to 10 days, to kind of do an additional screening. That would be a good way to utilize them. In the assessment piece, excuse me, once they're triggered as a positive screen for malnutrition, yes, the dietitian would be the one to go in and assess them. But with the diet tech for a follow-up, you could probably utilize them in some way, shape, or form to just do a follow-up to the intervention you're providing. That would be just my first thought on that. I know that the subjective global assessment is pretty similar to our malnutrition characteristics, some people have found, but I know, and that's what they use in Australia, but there goes my calendar reminder, so let me click out of there. There we go. But that's something that if we're using the clinical characteristics, then you could probably have the diet techs help with maybe getting some confirming weights. You know, like if you get a weight from a patient and you're thinking, maybe, I don't know if that's accurate, you could have them dig around a little bit and look for a more accurate weight, maybe that too. Or possibly with getting some intake information, maybe they could help with that. But the physical assessment piece needs to be done by a dietitian. And typically, you know, your high-risk patients are done by a dietitian. So I don't know if that helped or that answered your question, but I hope it did. This question says, do you have a website you could recommend to obtain the malnutrition assessment guidelines? So the malnutrition characteristics should be on the nutrition care manual, I believe. I know we have in PDF. And Bernard, we used to have a link on our website. Do we still have that, or do we have that link to the characteristics? I know way back, like years ago.
Yeah, we can send that link out.
We can probably send them out again. Yeah, okay.
Again.
Cool, so we'll do that. And I'll send out that PDF CMS, the entire proposed measures to you guys as well. Okay. CDI coders seem to use different parameters to identify malnutrition, such as BMI and albumin. We have shown and discussed with CDI coding staff and Aspen criteria. How should we address that as dietitians? Okay, so how we look at that is, if your CDI team in coding is still using BMI and albumin, you need to, of course, share with them, like you did, the Aspen and criteria. But the coding clinic guidelines still allow for BMI and albumin. We just find that most of the teams we work, well, all the teams we work with, we just ask them not to use albumin because we show them the articles, that are cited on the malnutrition characteristic criteria. We show those articles that support why not to use albumin, like how it's not a criteria for malnutrition because of the inflammatory response mainly. And we ask them not to query patient or physicians for albumin because if you guys are trying to educate physicians on the 6 criteria, just showing them like this is what we're using, you're not expecting them to do it. But what you don't want CDI to do is like to say, oh, we found possible malnutrition and have them queried and relating it to an albumin. That just confuses the physicians and it's not accurate. So just really working with CDI and coding on that, even though their coding clinic guidelines allow albumin, they don't have to use it. The BMI part of that, we will add, like some facilities have their 2 or more characteristics from our Academy and Aspen characteristics guidelines. And then they might want to write down a BMI to show support, and that's fine, but you have to have 2 or more criteria out of the 6 that we have in our guideline. But we let coding know again that the BMI is not an indicator. And so just you being able to show the support with the articles that support that as well. Now, on a side note, BMI as itself, underweight and morbid obesity, those are 2 BMIs that are considered comorbidities. So just like malnutrition impacts reimbursement and length of stay and the severity of illness of the patient and the risk of their mortality score, so can underweight and morbid obesity. And many times we dietitians are involved by calculating the BMI or seeing patients that are underweight. We don't see all morbid obesity patients, but those codes have been known to get denied as well. And so you might get a call one day and say, oh, did you see this patient? We need to support why they have a morbid obesity diagnosis code. So I think that's why BMI, aside from malnutrition, is something that continues to get looked at. So I hope that answered your question. And remember, if you have further questions, keep typing them in. We're going to get back to all of you. We have just a few more minutes. Excuse me, one second. Okay, I'm back. It says, here's a good one, and I haven't seen this come across, so this is a great question. Would a hospital be penalized if we identified hospital-acquired malnutrition? It's not on the list of hospital-acquired conditions. It hasn't been on the list. Malnutrition hasn't been on the list, and the Academy, I know, and Aspen have done a lot of work keeping it off the list. So as of right now, no. I haven't seen anything that's come across as a hospital-acquired condition, and that was something that we would definitely see and know. So they've done a good work. to do that. Okay, let me see. Other questions that we can answer today. What type of data should we collect? So we talked about it a little bit in terms of data. I definitely recommend tracking what the dietitians are writing for malnutrition. So if your dietitians, whatever they are putting out for malnutrition diagnoses compared to what the physician's actually diagnosing, you want to check that data. That's important because you want to see where the gap is in education and training, basically. So if your dietitian's writing one thing, your physician's not writing anything or another, that helps you kind of look at a quality program overall. So look at that. That's a good data report to look at, how many times it's the same diagnosis or different. And then it helps you kind of focus on what physician groups. And then the other thing, it is good to track the reimbursement piece. Now, some hospitals have a hard time figuring out how to do that. That's something that we provide to hospitals just as we work with a few hospitals just doing data, and that's all off-site support. And it's a process in which you can work usually with revenue cycle or decision support along with coding and yourselves, where you can say, okay, we need to figure out, how do we calculate the reimbursement related to the diagnosis of malnutrition? And that's something that we can help support. And the cost, and there was a couple questions about cost, so that's something that if you email me personally and we go over, what your needs are, then we base the cost on that because it really depends on what you need and how much time it would take. So we can definitely help you there. That was a couple of the questions. A lot of questions about the validated screening tool, and I mentioned the malnutrition screening tool, which is the MST. So you can look that up, and that's by Marie Ferguson. And also, just go on the evidence analysis library. There's a couple of other ones on there as well. There's some questions about a malnutrition example PES statement, and we do have some of those. So, Bernard, I hope you're taking good notes for me, but I'd be happy to send out a couple of the PES statements as well as a good example. And that's something that we've done on webinars before, just showing that. But if you think about it, you'd have a diagnosis of malnutrition, so from a PES statement, so moderate protein calorie malnutrition or severe protein calorie malnutrition. You don't want to put just severe malnutrition or non-severe malnutrition because that severe malnutrition back in the ICD-9 days actually linked to nutritional marasmus. And then now if a physician would, not when you guys write it, but a physician, if they were to write the same thing. So now medical diagnosis of severe malnutrition does link to protein calorie or severe protein calorie malnutrition, but we're not using the right terminology. So if we're writing severe protein calorie malnutrition, we should be writing severe protein calorie malnutrition. If it's not severe, then it's moderate. We don't have any guidelines as an association for mild. And then we put our etiology, so as related to what, and I always tell our teams and our coaches, we don't want to see poor appetite. Because you might be saying, well, that's what it's related to. Well, yes, but what is causing the poor appetite? That's your, etiology piece or disease process. Well, what about the disease process is causing the patient to lose weight, to not eat? That's how we really dig in and figure out what's going on with that patient, because we can't give an intervention if we don't know the why behind it. So yeah, we can send out a couple of those statements. And then the signs and symptoms piece would be your 2 or more criteria based on the clinical guidelines. Okay, well, Jesus, top of the hour. So there's some of the answers for you. And now I'm just going to go ahead and finish up our presentation. I have a couple more slides I want to share with you all. And then we'll get back to you with the rest of the answers. So we'll email them out to you as you ask them. And then one of my favorite things to share with you next year, our Good to Best Educational and Training Conference in San Diego, California, March 16th to the 18th, 2018. This is our 12th annual one. I'm one of the co-planners with Bernard and usually speak each year, but amazing speakers, topics, educational opportunities for both you, your staff, your food service director, chefs, dietitians, executive team. It is a awesome weekend of just empowerment, education, training, 18 or more CEUs. Awesome venue. And today, just for being on the webinar today, we'll give you half off of registration. So instead of $200, $100 if you want to go ahead and sign up. Hands down, the reviews and results we get back every year from our conference. People have been to conferences all over the United States, internationally, and we always get positive feedback that this is the best of the best. So we're very excited to share that with you. A lot of good leadership, food service, clinical, educational topics. So please, if you're wanting to sign up today, and you get $100 off your registration, so half price for being on our webinar today. And then join us again in a few months, August 15th. We're going to have the next in our webinar series from the Nutrition Division at DM&A. And this is your surgical weight loss patient losing more than just weight? We get a lot of questions about bariatric nutrition and malnutrition and how to tell the difference, and is it really malnutrition or not? And so if this is for you, sign up. Amazing speaker, Kenna Glick. She is one of the only board-certified weight loss and obesity management dietitians in the United States. She's the only one in Georgia, and she's also worked with us in the nutrition division and is a success coach. She works full-time in a bariatric center, and I'm just excited to have her expertise on the call. And then we'll have 2 more coming up in November and February. So we really encourage you to join and to sign up for them. It is just an awesome educational opportunity. And
thank you, Michelle.
Bernard, thanks.
Yeah, I can close it out. So by the end of the week, we'll be sending out a post-webinar email, which will include all the following. This presentation, a link to that, the CEU certificate for RDs and CDMs, a link to the webinar recording so that you can share with your team, a link to register for the next webinar, the Good to Best registration special that Michelle mentioned for 50% off registration. We'll also include the links to all the resources mentioned in Michelle's presentation and also in the Q&A session. And we'll also include responses to some of the questions that we didn't have time to get to today. So folks, if you have any immediate needs or require any support whatsoever, please don't hesitate to contact us for a free consultation with Michelle or any one of our excellent success coaches. We here at DM&A are here to help you. Thank you once again, Michelle, for this wealth of information, education on CMS quality measures and malnutrition. You did an excellent job. On behalf of Michelle and myself, on behalf of Michelle and myself, everyone for attending our webinar. Have an awesome rest of the day. Goodbye, everyone.
And thank you for all you do. Thank you.